I think we'll get started. Good morning, everyone. Welcome to EMS's Friday virtual news briefing, which is the second of three we will be presenting with support from the Robert Wood Johnson Foundation, a national philanthropy dedicated to promoting health equity. I'm Sunita Sarabji, Ethnic Media Services Health Editor, and your moderator today. And we wanted to give a shout out to RWJF, who supported the first National Expo of Ethnic Media in New York City way back in 2005. It's an honor to help expand its communications outreach to the ethnic media sector. Today, we explore the nation's largest health insurance program, Medicaid, which currently provides free or low-cost coverage to more than 83 million people in the US. But approximately 23 million people, including 3 million children, have lost or stand to lose coverage due to the end of pandemic-era continuous coverage protections, also known as the Great Unwinding. 69% were disenrolled, not because they were ineligible, but because of paperwork and procedural technicalities. Expanding Medicaid to close the coverage gap is one of the most significant ways states can increase coverage rates and achieve health equity, particularly after the unwinding. Yet 10 states, largely in the South, still choose not to expand their Medicaid programs under the Affordable Care Act. These states have some of the worst health inequities in the nation. So speakers this week will discuss how to strengthen the Medicaid program to provide equitable health coverage to all, and why states must act to close that coverage gap that disproportionately affects communities of color. I'd like to thank Tricia Woodcomb of RWJF, who helped us tremendously with organizing this briefing today. Our speakers today include Katherine Hempstead, who is the Senior Policy Advisor at the Robert Wood Johnson Foundation, Stan Dorn, Director of the Health Policy Project at UnidosUS, Martha Sanchez, Health Policy and Advocacy Director at Young Invincibles, and a familiar face, Joan Alker, Executive Director and co-founder of the Center for Children and Families and Research Professor at Georgetown University. We asked reporters to enter questions in the chat. Our speakers are also encouraged to answer questions in the chat throughout the conference. And we will, as always, send a video of today's briefing along with expanded bios for each speaker later on today. We will also send video experts of the presentations early next week, which we encourage you to use on your social media channels. So first, we welcome Katherine Hempstead of RWJF, who will provide an overview to kick us off. Welcome, Katherine.
Thanks, Sunita, and hello, everybody. I'm really happy to sort of kick off this afternoon briefing, and I'm joined on the panel by some real Medicaid experts. So I feel a little bit in a funny place to be giving the Medicaid overview, because there are some super expert Medicaid people that are going to follow me on this panel. But they're going to really get into the weeds about redetermination and unwinding and some of the really gripping issues of the day. And I've been tasked with giving some very sort of high level background about Medicaid as a program. And hopefully it'll sort of hit the right level for the median listener on the call. And then to also talk a little bit about what the foundation is interested in with regard to Medicaid and coverage in general. So I'll sort of close by talking about briefly about some of our work and what we really care about in this space. So are my slides up? I can't necessarily tell, but we can put up my slide. And I'm Kathy Hempstead. I'm in the policy department at the foundation, and I mostly work on coverage and other sort of healthcare policy related issues. So you can go to the first slide now, which is sort of the background, the first background slide. And, you know, again, very high level. Medicaid is a very complex program, and you could spend 100 hours talking about the details of the Medicaid program. You can go to the next slide. But this is a program that is almost as old as me, not quite. I just celebrated my 60th birthday, and Medicaid is 59, Medicaid and Medicare. Can you go to the next slide? Would that be okay? Created in 1960.
Hold on 1 second, sorry.
Sure. No problem. Perfect, thank you. Yes, so this makes more sense now that you can see that the Medicaid was created in 1965, and I just realized that our birthdays are at the same time in the year, and it's I'm almost, Medicaid's almost as old as me, but not quite. So Medicaid just turned 59. It's not a new program. It was created the same year as Medicare, but it has changed a lot over the years, and we're going to talk about some of the recent events during this call. Unlike Medicare, which is a completely federal program, Medicaid was designed as a federal-state partnership, which means that there's both federal and state money going to the program in each state, although the federal government spends much more, and the amount that the federal government spends depends on the sort of average income in the state. So in poorer states, the federal government is paying more. But it means that when we talk about Medicaid, we're really in a way talking about one big program, but at the same time, we're talking about 50 different programs, because each state has their own Medicaid agency. If you're covering this and you're new to it, each state names their Medicaid program in different ways. Sometimes that can be a little bit confusing. In some states, and maybe this will come up in the conversation about redetermination, counties have a more important role in enrollment and eligibility redetermination than they do in other states. So that can be sort of an interesting factor when you're looking at how the Medicaid program actually runs. And most states, not all, but about at least 3/4 actually contract the Medicaid program out to managed care organizations, MCOs, or insurance companies. So sort of the face of Medicaid and what the Medicaid program looks like, I think is very hard to get a grasp on, because it's different, looks different in different states, and it's you know, different managed care organizations, different companies. So it's a, you know, it's a little bit of a complicated part of coverage to wrap your arms around if you're new to it. You can go to the next slide now. Thank you. So, you know, viewed as a whole, the Medicaid program is very large. It's the largest single source of health insurance in the country, but it is, you know, sort of like fragmented into 50 different state programs. And most recent estimate, approximately 82 million people enrolled, and about close, not quite half of the enrollees are children. And, you know, roughly, this is sort of back of the envelope, but close to 1/4 of the population is enrolled in Medicaid. So it's a very large program. And the major enrollees are children, pregnant women, low-income adults, also low-income seniors, and people with disabilities, various kinds of disabilities. So there's many people that are touched by the Medicaid program. And this image shows a little bit of the sort of specific details. Medicaid pays for the vast majority of long-term services and supports for low-income seniors, because the Medicare program doesn't cover long-term services and supports by and large. But that's certainly a topic for another day. And, you know, many individuals with disabilities and many people with sort of special healthcare needs, children and adults, are covered by the Medicaid program. So Medicaid touches almost everyone. I myself have an adult son with a disability that has, you know, been in the Medicaid program and will be for the rest of his life. It's a very, very large program that touches many of us. You can go to the next slide here. Thank you. So Medicaid was originally designed for specific kinds of low-income groups: low-income elderly, people with disabilities, children, pregnant women. Other sort of requirements for eligibility, since it is a different program in some ways in each state, is to be a resident of the state. And it's limited to citizens or qualified immigrants. And for many qualified immigrants, there's a 5-year waiting period. And this would be something that, Stan in particular could talk a lot more about the details there. You can go to the next slide. Thank you. And over time, one of the things that we wanted to mention today is this sort of expansion in Medicaid eligibility that accompanied the Affordable Care Act. And this this umbrella, I think, which is an image from the Kaiser Family Foundation, is sort of I think a good graphic showing, what was sort of covered by traditional Medicaid, and then this attempt to expand Medicaid coverage to include low-income adults who are not parents, or not disabled, who don't fall into those categorical eligibility groups. So this was something that came with the ACA. They created an adult expansion category for low-income adults aged 19 to 64 with income below 138% of the federal poverty limit. But due to a legal challenge and, some litigation that, kind of cutting to the chase, the Supreme Court ruled in 2012 that the expansion of Medicaid under the ACA was optional for states, and that states didn't have to do it. And that is, one of the things that has become, a really important coverage problem, is the fact that some states have chosen not to expand Medicaid under the ACA. You can go to the next slide. Thanks. So the Medicaid coverage gap, when people talk about that, we're talking about the states that have not expanded Medicaid under the ACA, the non-expansion states. And Sunita referred to them at the top of this. And this is a nice map that shows that, yeah, most of them are in the South, a few are not. Wisconsin has partially expanded. It's kind of a detail. It's done more than the other states because it has expanded up to 100% of FPL. But the big picture is the same. These are the non-expansion states, and it creates a coverage gap where there are approximately 2 to 3 million people, predominantly populations of color, who's are in a very unfortunate and unfair situation, which seems like a really sort of cruel outcome of the way these policies have worked, where they end up having income below 100% of FPL. So they're quote unquote too poor to be able to use the ACA marketplace for subsidized coverage, but yet they don't qualify for their state's Medicaid program because their existing eligibility limit is so low. And so these are very low income people that simply have no affordable access to coverage. So this is, something that is a real preoccupation for those of us that are really interested in coverage. So this is something that, over time, as you can see, most states have taken advantage of the opportunity to expand Medicaid under the ACA. And I think, many people think that ultimately all these states will, but in the meantime, and it's been a long time, there are all these people that don't have access to coverage, and they're by definition very low income, and some of these states obviously are very large states like Texas and Florida. Okay, you can go to the next slide. Thanks. I know I'm already taking up too much time, but I wanted to just touch on the issue of coverage for immigrants. In one of the things that we are interested in is tracking and sort of encouraging states that are thinking about expanding coverage to immigrants, and they would have to use state funds to do that. But a number of states have used the Medicaid program and used state funds to expand coverage to people regardless of their immigration status. The map shows the states that have done things like this, and mostly it's through the Medicaid program. Sometimes it's through the marketplace. Sometimes it's through combination. But these states haven't necessarily covered exactly the same population. Some have just covered kids, some have covered adults. Illinois covered seniors, so that the map creates a little bit more homogeneity than there really is. But there's a little bit of effort toward that. And obviously California, New York, those are really big states. That makes a big difference, but you can see it's mostly something that's happening kind of on the coast, and it's certainly not happening in lots and lots of states. So, and I'll loop back to this issue at the end. I think you can go to the next slide here. So if you're covering Medicaid, some of the things that people talk about sort of have to do with eligibility, who's eligible for Medicaid, and problems, you know, with people that don't have Medicaid eligibility. So there's the coverage gap. There's the issue of coverage for immigrants. I know something that will come up today is it's a long-standing issue, quote unquote, churn. People who are eligible for Medicaid and then due to either slight variations in income or administrative implementation issues lose their coverage and have to get back on. And it's very costly to the individual. It's also costly to state agencies, but the sort of inefficient way that people get and lose their eligibility for Medicaid, and people call that churn. And I think what we're really going to focus on today is the Medicaid unwinding, or the redetermination that's been occurring over the past year, which is sort of churn on steroids, maybe, because 3 years of Medicaid enrollment without redetermination was then sort of finished by a big episode of redetermination in all states. And I think our other panelists are going to talk about some of the very unfortunate consequences that have occurred. So this is sort of a special case of a general problem, which is that it's very hard for lots of people to stay on Medicaid, even though they remain eligible, because of the bureaucratic hoops that people need to jump through. So, it's possible that all the trouble that has accompanied this redetermination process is going to translate into some better solutions for making enrollment more continuous. And I'm sure that's going to come up later. And the other issue that I think comes up a lot when we talk about Medicaid are just different questions about access, and which really kind of also means quality of care. You may be interested in or find people in your community talking about the adequacy of provider networks, whether people that are enrolled in Medicaid can actually get access to the care they need. And, particularly this comes up with regard to behavioral health and specialty care, where, because of the way Medicaid is financed, providers are not paid as much by state government or by the MCOs they're contracting with to care for patients in Medicaid, not paid as much as they would be in employer insurance or even Medicare. So we sometimes then see it's, difficult to get a sufficient supply of providers. And that's especially true with specialty care and with behavioral health. So that's something that is kind of an ongoing Medicaid issue. Access to home and community-based services is another big policy issue in Medicaid, where people are on very long waiting lists in many states. And that's something that is, there's a constant unmet demand problem for people that are looking for those services. And we're also hearing about prior authorization and, sometimes people not getting that care that they should get. And, related, I didn't list this, but was just the issue of, whether all medications are covered and people get access to all the care that they need. So I think that today we're probably focusing more on eligibility, but just wanted to tee that up. If you are, covering Medicaid and thinking about what are some of the interesting issues for journalists to think about with Medicaid, there's definitely a lot of interesting access issues. I think we can go to the next and maybe the last slide. Okay, yes. So, the foundation, we are very, very committed to making sure that everyone has access to affordable coverage. And we believe that healthcare is a right. And because of that, we have some policy priorities around coverage. And one of them is to close the Medicaid coverage gap. That is the single largest contribution that could be, within our given system that could contribute to reducing the size of the uninsured population. So we have, over the years, funded so many studies on, documenting the benefits of expansion in the states that have expanded, both the benefits to individuals, the economic benefits to the community, the reduction in bankruptcy, the increased labor productivity, everything. And at the same time, sort of laying out the cost of non-expansion. So, we're interested in demonstrating that and making that case to try to, sort of push things along in states that have not yet expanded. And we also fund a ton of advocacy work in that space. So that is one of our very, very top priorities. And expanding coverage for immigrants is another really important priority for us. And we have an exciting project with RAND that is not quite ready to release yet, but in September, and this might be really interesting for journalists out there that want to cover this issue, but it's going to be a sort of a calculator that would show the costs and the benefits of covering different segments of the immigrant population, regardless of immigration status in different states. And it's to be used by advocates and policymakers and people that are interested in trying to expand this coverage. And there'll be lots of other resources too. And that's something that we really hope that the advocacy community is going to be able to use. We're also very interested in trying to contribute to the reduction of churn in Medicaid because, redetermination aside, it's a constant problem that separates people from care and prevents people from.
Katherine, I'm so sorry.
Yep.
We are past our timeline. And I really hate to interrupt because this is such useful information. There's several questions for you in the chat. Could you answer them there?
Sure.
Okay, I very much appreciate it. And I'm sorry,
Sure.
We'll come back to you if there's time at the end.
Absolutely. Thanks.
I appreciate your comments. They were tremendously useful. And like you see, there are several questions for you in the chat. So we hope you can answer some of them there. We move on to Martha Sanchez of Young Invincibles. Martha, welcome.
Hi, everyone. Pleasure to be here. I am Martha Sanchez. I'm the Director of Healthcare Policy and Advocacy at Young Invincibles. Young Invincibles, affectionately referred to as YI, is a national advocacy and research organization, nonprofit organization uplifting the voices of young adults ages 18 to 34, advocating for policies that improve their access to healthcare, higher education, and workforce opportunities. We were an organization founded back in 2009 during the drafting era of the Affordable Care Act. We pushed for young adults to be able to stay on their parents' health insurance until the age of 26, and since then have continued our advocacy efforts to make sure that young people have access to affordable quality healthcare, along with all of the other policies that support the economic well-being and prosperity of this population. Despite our name, we understand that young people are not invincible. We need healthcare, we get sick, and we face a number of chronic issues. As a matter of fact, a 2019 study by the CDC showed that at least half of young adults ages 18 to 34 have at least one chronic condition. That can be obesity, it can be diabetes, cancer, mental health. And we know that since the COVID-19 pandemic, a third of young adults are facing a mental health crisis. And that's actually half of young adults ages 18 to 24 who report symptoms of mental illness, depression, anxiety, and loneliness. So we know that there is continuous need to improve our health and our well-being, and that these generations, this population is the future of our workforce and economy in the US, and we cannot afford to continue to regress when it comes to our health. Young adults remain the highest uninsured population of any age group. And when it comes to Medicaid, we make up 47% of that Medicaid coverage gap. And like I said, a third of us have experienced a mental health crisis. And when it comes to our physical health, more concerning in recent months are all the stats and studies that we're getting, like from the American Cancer Society, which reported that we are increasingly suffering from more severe cancers, including colon cancer. And so diseases that would normally affect older populations, and that the Affordable Care Act has actually built in recommendations for free screening for older populations, are now affecting younger populations. And we're in a crisis where our healthcare systems are not meeting the needs of our health of young people. In addition, what's so interesting about the 18 to 34 population is that it's a stage of transition. Many young adults who are from low-income families have grown up on Medicaid and are transitioning out of Medicaid because there's no Medicaid expansion, or because they are now becoming students, they're enrolled in a university and are being sold student plans if they have left the state, or they, don't realize that they even have access to the Affordable Care Act. They don't know what steps to take to enroll in a private insurance plan, and they still don't realize the affordability of these plans, despite the American Rescue Plan and the advanced premium tax credits that we currently have. So at YI, our goal is to provide health literacy to young people. We provide them consumer information. We want them to keep their Medicaid if they can, if they are eligible. We want to make sure that they know that they need to renew it. But at the same time, we want to make sure that they understand that if they are no longer eligible for Medicaid, that they have options to affordable care, and we want to fight to make sure that those options remain there. But there are a number of policies that we need to address in order to make sure that those who are eligible for Medicaid get it, those who should be eligible for Medicaid get it through Medicaid expansion, but those are currently in Medicaid, that they understand the benefits and the value to it. So I grew up on Medicaid and SHIP, and I never really understood all of the benefits that I had, unfortunately, until I transitioned out as a young college student. So my parents understood the value of Medicaid. They made sure that I got my annual checkup, and the school made sure that I had my vaccinations, and that I took advantage of dental care under Medicaid. But I had no idea of the mental health benefits. And we've actually have heard this from other young adults. We had a young advocate who shared that he would have taken advantage of mental health resources, but he had no idea that it was covered by Medicaid, because, as you can imagine, the explanation of benefits when you're under 18 goes to the parent, and their parent had a stigma against mental health resources. And so there are policies that we can do to strengthen the interactions that people have with this system, to make sure that it is language accessible, and to make sure that they are actually using their coverage and are not just frustrated by maybe a wait list or not getting an immediate appointment, because the ability for people to build good habits with Medicaid is going to affect their ability to continue those habits as they have to move into other systems of healthcare. So at Young Invincibles, we continue to support Medicaid expansion as well as health literacy. We continue to support efforts by the Department of Education to play a bigger role when it comes to Medicaid, whether that is through Medicaid reimbursement to schools for services, or through more awareness to college students about their options and eligibility. Overall, we understand that Medicaid is extremely beneficial. There's nothing better than free 99 for young people, and it's about our health and protecting the future of our economy. So with that, I encourage everyone to think about ways that we can not only expand the program, but strengthen its current form, so that our families, including if they are mixed status families or immigrant families, can really thrive in this country. Thank you.
Sunika, you're on mute.
Martha, thank you so much. That was a terrific presentation. We're going to save all questions for the end of the briefing today. We'll take questions from reporters for the last perhaps 10 to 15 minutes, depending on how this timeline adjusts. So I thank you for your excellent presentation. We move on next to Joan Alker, who reporters have seen previously on our briefings. Joan, welcome.
Thank you, Sunita and Sandy. We love to work with Ethnic Media Services, as we have done for many, many years now. And I'm especially happy today to speak to you all because your communities have a real need right now to learn that many children who have lost Medicaid during this unwinding process I will discuss are still eligible, and we need to get them back enrolled, particularly in back to school right now. This is a really important moment. So let's start with my slides, and I'll try to be quick. I'm Joan Alker. We are a center at Georgetown University. Our mission is to ensure that all children and families have access to high quality, affordable health care. So let's go to the next slide. We have been tracking very, very closely what has been happening with the so-called Medicaid unwinding. And a little bit of background. During the COVID-19 pandemic, during the public health emergency, Congress passed a law, and former President Trump signed the law that required states to keep everybody enrolled in Medicaid. And states got extra money to cover their costs. So nobody could lose their health insurance because we were in an economic crisis and a health crisis. And Medicaid is a first responder for both of those kinds of crises. Now, most states over the last year have checked eligibility for everybody on Medicaid. This has been a huge process. As Kathy said, 1/4 of people in the country, and actually using other data, half of children in the United States, and a larger proportion of communities of color, their children are covered through Medicaid. And imagine that everybody had to get their eligibility checked. It's been a huge undertaking, and many mistakes have been made. So we have been tracking very carefully the data on changes in enrollment. And this is across the country, about 15 million fewer people are enrolled in Medicaid as this process continues. I'm going to talk more about children in a minute. You see the states that are darker here have lost more people, Texas and Florida, California leading the way. But if you go to the next slide, and here we're looking in percentage terms, you see that California actually in percentage terms has done pretty well. And the states that are dark in this map are the ones that have lost a very large percentage of their enrollment. So again, Texas is still right up here. Utah, Colorado, Montana, some of the highest percentage losses. Let's go to the next slide. So now I'm going to talk to you specifically about children. You know how important Medicaid is to cover children. We just talked about that, particularly for communities of color and mixed status families, immigrant families. Medicaid is vital. And we knew when this unwinding started that many of these children that would lose coverage would still be eligible. In fact, the federal government estimated that 3/4 would still be eligible. So Medicaid is where they should get their health insurance. We were very worried and in fact predicted that 6.7 million children would have a gap in coverage, and we have now a decline of 5.5 million fewer children in Medicaid. We don't know the race and ethnicity of these children, but we do know that communities of color are badly, badly impacted by this. And many of these children remain eligible. So let's go to the next slide. We are tracking by state, and we did a report on this a few months ago. There have been huge differences by states. How states have responded to this challenge. We have seen some states that are really rethinking their eligibility systems and embarking on new policies, which are very exciting. For example, covering all infants until they're age 6 and they're in school continuously. Parents do not have to worry about losing the coverage, and we can all focus on making sure those children have a healthy start to life. And we have 11 states and the District of Columbia that are seeking to improve their policies. We have other states who went out of their way to protect children in this process. North Carolina, Kentucky, they delayed the process for children. But we have some states who have doubled down on kicking children off, even though we know many of them are eligible. And you see here, Texas again has led the way, a truly shocking number that 1.3 million fewer children are enrolled in Texas. And in Florida, it's over 500,000. So in these states, these non-expansion states, Florida, Texas, Georgia are the 3 biggest. When the parents lost coverage, they fell into a coverage gap. But the children often lost it too, and they shouldn't have because they remain eligible. So let's go to the next slide. The next slide looks at the percent decline. Okay, so here, of course, we're accounting for state size. And you see that Utah, Colorado, Texas again comes up. They've lost almost a third of the children, fewer children in their Medicaid programs. I want to mention as a side note that quite a few of the states with high percentage disenrollments have very large Native American communities. So I'm very worried about Indigenous children having lost coverage while remaining eligible. So if you are working with communities, particularly in these states that you are seeing that are red, dark states in my maps, we need to get the message out to parents that the child is probably still eligible, and seek assistance in your communities to get those children re-enrolled. Get help from your pediatrician, from your clinic, from your school, from your childcare provider, from your church, trusted community resources to help make sure those children get the coverage they're eligible for. If we go to my final slide, and I know Stan will talk more about many of these issues, we can go to the final slide. If you're interested in our data, the final slide has some links for you. We have, oh, sorry, I do have one more slide, and I'm going to skip over this. This is just to say that in some states, the application process is getting really backlogged because we have so many people trying to come back. But in any event, here's a couple of resources for you. If you want to dig more into your state's data, we're happy to help. And with that, I'll hand it back to you, Sunita.
A quick question for you, Joan, and this isn't a quick question by any means, but with the children that are disenrolled, what are the safety nets for them? Where do they go for things like vaccinations before starting school?
Yeah, so there are, some clinics they can go to, some of the pediatricians. I mean, most children on Medicaid actually don't have trouble finding pediatrician. There are issues with specialty care, but what we've heard directly from families and the research supports is they do have a direct source. So, but of course, when they're uninsured, they can't pay the bills. And so a few things are happening. First of all, parents are just putting off care, right? Because they're not insured. So they're just hoping their child doesn't get sick. And another problem that we've heard of is that children cannot get their medications, right? So many children have asthma, they need their inhalers, they have behavioral health conditions, they need their medications, and they're having to miss medications, skip medications and treatments that they need while they're uninsured. And this is why any gap in coverage is not acceptable. Children are not expensive to our healthcare system, but they need regular care. And any parent knows that, right? So even a short gap exposes the family to large medical bills and undermines the often routine, but regular care that children need. They're less able to learn. So that is why we really need to get the message out to your communities that many of these children, excuse me, are still eligible, and let's get them re-enrolled in Medicaid and CHIP.
Joan, thank you so much. We move on to our final speaker for today, Stan Dorn of UnidosUS. Stan, welcome.
Thank you so much, Sunita, and thank you for inviting us, including us on this amazing panel, and having a chance to talk to reporters who inform historically marginalized communities about what's going on in their lives. I'm very excited to have a chance to speak with you today. So I lead the health policy team at UnidosUS. I'm going to share my screen if that's okay. That's the wrong thing to share. Let's see. Here we go. Let's try this. Let's see if this works. Can you, what are you seeing? Are you seeing the full slideshow view?
We are, yes.
Okay, excellent, excellent. We're the nation's largest Latino civil rights and advocacy organization, and I'm going to focus on what's happening with communities of color as a result of the great unwinding. Now, Joan was absolutely right. We do not have solid numbers for race and ethnicity reported by states, and we're not going to find out the ultimate story for a couple of years. But we were able to use a simple method to come up with conservative underestimates of the impact on communities of color. We said basically, if you assume that everyone, white, Latino, African American, everyone enrolled in Medicaid is equally likely to be terminated, then just based on who's enrolled in the program, how many people have lost coverage in each racial and ethnic group. Now that underestimates the true magnitude of harm, because we know that in fact, Latinos, African Americans, Asian Americans, Pacific Islanders are all much more likely than non-Hispanic whites to be terminated. But even if we make the conservative assumption that everyone is treated in just the same way inside the Medicaid program, the losses have been staggering. For each community of color, the reduced number of people covered by Medicaid far exceeds the biggest one-year drop in history. So for Latinos, for example, Medicaid covers almost 4 million fewer Latinos now than it did at the start of the unwinding. The biggest previous annual loss happened in 2019, when the number of Latinos covered by Medicaid fell by 1 million. This is more than 3 times the size. African Americans, nearly 3 million African Americans at a minimum have lost Medicaid during unwinding, again, using very conservative methodologies. The largest previous loss took place in the 1990s, when welfare reform legislation passed in Congress, and the number of African Americans covered by Medicaid fell by 700,000. It's now 2.7 million. Same thing for all these other communities. So it is an absolute historic drop that we have seen. Now, as other speakers have said, most of these terminations have resulted from paperwork, red tape, administrative factors. So only less than a third of everyone who's been terminated was actually found ineligible. The rest were terminated because of administrative factors. The state sent out a request for information, they didn't get it, or it didn't come in the right form, or what have you. The KFF, one of the sources that Joan pointed to, did a survey where they asked people, and I think it was January, February of this year, so what happened to you during Medicaid redetermination. About 30% of people said they never got a notice of termination. They didn't, but for those who did get a notice and tried to renew, 60% almost 60% ran into serious procedural problems. They couldn't get through on the call center. They didn't know what forms to complete. They actually knew what forms to complete. They filled them out and sent them in, but the state lost them. Things like that can really get in the way. And these paperwork losses were the main drivers in what took place. Another key lesson learned from the unwinding, in addition to the disproportionate impact on communities of color and the central role played by administrative burdens, is the enormous differences between states. And I want to thank my colleague Joan for the fantastic work that she and the folks at CCF have done, putting these numbers up, week after week after week. So we looked at the numbers as of 2 weeks ago, not quite up to date. But it's astonishing. The 5 states with the greatest drops of children's Medicaid coverage were all, on the median among them was a 29% drop. The 5 states with the least losses all had a 2% or less loss. So what this means is that your ability, the identical family has a very different likelihood of getting health care based simply on the state in which they happen to live. Here's another way of looking at this. Again, sort of simple arithmetic. If every state in America did as well as the 10 best states in protecting children's coverage, then instead of losing 5.5 million children, we would have lost 800,000 children. More than 4 million additional children today would have Medicaid. They would get their prescriptions filled. They could get developmental screens so that that delays get picked up early. If God forbid somebody is riding their bike and gets hit by a car and they go to the hospital emergency room, the family wouldn't be subjected to enormous financial burdens. 4 million children. The price America pays for giving states enormous authority over the details of Medicaid programs is extremely high. That's an important lesson of unwinding. Now, as with so many other aspects of the pandemic, the great unwinding shined a spotlight on longstanding problems in Medicaid. And exactly as Kathy said, we want to make sure that we learn the lessons, that we take advantage of this moment in the spotlight to greatly improve these programs so that nothing like this ever happens again, and these programs do a much better job of providing equitable healthcare to everybody who qualifies. And we see 2 important directions forward for improving the programs in the future. One is to completely eliminate administrative burdens for as many people as possible. 3 ways to do that. 1, paperless eligibility. For as many people as possible, use information the government already has to qualify people. The government has income tax information, quarterly wage information, records from what other programs. Instead of saying, we're going to take away your health care until you tell the government what it already knows, we ought to be saying it's the obligation of states to use available data to renew and qualify people whenever possible, thus eliminating paperwork burdens for them. Second, when there are forms that must be filled, connect families to expert, linguistically accessible, culturally appropriate sources of assistance so that people can pick up the phone and talk to somebody who can help them figure out what the heck to do and help them fill out those forms, upload the documents. That way the administrative burden is lifted off a frequently overburdened and under-resourced family and given to somebody who knows how to handle the situation and can help that family move forward. And third, as Joan mentioned, continuous coverage. The longer people are covered, the fewer opportunities people have to lose their health care because of missing paperwork. So these 3 strategies are key to make administrative burdens completely irrelevant for as many people as possible. So that's the first general approach that we need to take. The second is we have to do a lot better job of giving states incentives to do the right thing. There was a question in the chat about, well, why would a state not want to enroll as many people in Medicaid as possible? There's a financial issue. That is, the state pays a percentage of the cost of people who are enrolled. Some states don't particularly want to pay that money. There are other factors involved as well that I'm not going to speculate on about values and priorities, but we think that some changes at the federal level can give better incentives for states. So number one, we think there need to be very clear, explicit standards for state performance. At least X% of all redeterminations are paperless, for example, based on data matches, things like that. And if a state exceeds those standards, it should get bonus payments. Just as we did with the Children's Health Insurance Program back in 2009, we should do this more broadly for Medicaid and CHIP as well. Second, when a state does not meet the minimum standards, we don't, right now, the nuclear war is the only option. The federal government says, all they can generally say is, we'll take all your federal money away. Well, that's ridiculous. Nobody's ever going to do that. A much more sensible approach, we think, would be to take a portion of the state's federal money and put it on hold, defer the payment until the state has met its obligations, has come up to those minimum standards, and in the meantime, protect families by stopping them from being terminated for paperwork reasons, or making sure they get granted eligibility unless there's known reasons to say no, things like that. But so incentives to meet and exceed minimum standards. And third, when states get audited for errors, audit them for errors in both directions. Today, if you cover someone by mistake, you may get audited for an error, and there may be headlines in the state newspaper that talk about what a terrible job you're doing. So the incentive is, in case of doubt, don't cover the people. We think that if there's an error in denying healthcare to people, that too needs to be counted in the auditing system. So states have incentives not to throw people off in case of doubt, but to do the right thing and actually find people to be eligible. So, I'm trying to stop sharing. How do I stop my sharing? This is so terrible. I'm a merely okay baby boomer. I'm like way older than Kathy, so I can't even figure out how to stop sharing. So anyhow,
Don't worry. Jessica, could you stop Stan's sharing? She might be able to do. There we go.
Oh,
all right.
Okay. Hooray. Thank you. So if you
All
can't do
right.
it yourself, a knowledgeable source of assistance to help you overcome those administrative burdens.
Thank you so much for your excellent presentation. We're going to go to questions from reporters. Orhan Arkut has the first question. Orhan, please identify your news organization and the speaker to whom you're addressing your question. Orhan?
Yeah, are you able to hear me? Yes.
Yes.
Yeah, Orhan from Zaman America. So I have two questions actually. So do you think the doctors struggle to treat the Medicaid patient because the state rate haven't kept up? This is the first question. The second question, as far as I heard from the community members, so most of the doctors, they don't work with the Medicaid. So they have the option. That's what I understand. In network, they don't work with the Medicaid. So how Medicaid might work with more doctors to get more coverages for patients?
Who would like to take that question on? Katherine, would you like to? Oh, Joan, you raised your hand. Please
Sorry.
take the question on.
Well, Kathy can add, I would say a few things. So most states are running Medicaid through managed care organizations, as Kathy talked about. So it's the responsibility of the managed care plan to have a good network. Now, when you look at the research, there's actually good access for many things in Medicaid. As I mentioned, for primary care, accessing, for example, pediatricians or OBGYN care, leaving aside where there are shortages in some states now, Medicaid does very well, the data suggests. Where there are problems is more accessing specialty care, behavioral health, dental care, other kinds of specialist care. And so, yes, I think it's partly the rates, but it's also that we have problems across all payers. on behavioral health. We have a shortage of providers for a lot of pediatric specialties, and there are long wait lists even when you have private insurance. So sometimes it's a Medicaid problem that might be related to the managed care plan not doing a good job or Medicaid not paying enough. But sometimes it's a system problem that we have in our healthcare system. It's not just a Medicaid problem.
Thank you. And Katherine.
Just quickly, I would add that over time, as the Medicaid program has gotten bigger, the difference between Medicaid and other segments of health insurance have gotten smaller, and certainly, you know, specialties like pediatrics, it's really difficult not to accept Medicaid. But I just wanted to mention that one of the things that we have done is we've released some provider network data for Medicaid and marketplace plans. And if any reporter is interested in looking at their own neighborhood and sort of seeing what access is to different specialties and how, you know, there may or may not be similarities and differences between the two market segments, just you can follow up with me after and I can point you to that resource.
Excellent, thank you. Henrietta Burrows, please identify your news organization, your question, and who you'd like to answer your question.
Thanks, Sunita. Both of my questions in the chat were answered, like the difference between Medicaid and Medicare, and also why some states didn't want to allow their eligible members to be dropped. Now, Orhan brought up a question I'd like to have clarified, and that's many doctors don't want to take on Medicaid patients. They talk about the paperwork, they talk about the long time to get compensated. So what solutions would you have? What incentives would you give doctors to take on Medicaid patients?
I'll ask that question to Stan and Martha. Let's get you in.
Yeah, I think there are, hearing that, I'm reminded of a moment when I was doing advocacy in California, and I was in a meeting with some state officials who said, you know, we were talking about that you need to raise the rates and you also have to cut the paperwork for the providers. And one of them smiled and said, well, if they provide the service and they don't get paid, that's the perfect cost containment. We get the service, you don't have to pay anything. It's a problem. I mean, picking up on Joan's theme, it's a problem with private insurers as well, the paperwork burdens they put on physicians. It's you know, AI has now been weaponized by a lot of private insurers to deny claims and, you know, make the providers jump through hoops. But with Medicaid, it's also, there's an extra layer of burden. These are old programs. The states, I mean, one of the things that we found was that the states with the worst problems in terms of people losing coverage had invested the least amount of money in their eligibility infrastructure. So ultimately, it's a question of values. Are the state's officials willing to invest enough money in running a Medicaid program that they would trust with their own family's health care? Some are willing to make those investments and have systems that work for families, that work for providers, and others are not.
Martha, anything to add?
Yeah, so agree with the need to address reimbursement and paperwork. But at Young Invincibles, you know, we really try to make sure that we're advocating for the medical workforce, including the mental health workforce, to be diverse and culturally competent and reflective of the current population. And when we talk to young people, many of them don't end up, for example, going into a psychology field or a mental health field because of the cost of tuition, because of the cost of getting a master's degree. And you can look at the data and know that, you know, once after a bachelor's, when it comes to your stats for how many African Americans and Latinos graduate with a master's degree, you're in the single digits. And a lot of that has to do because of income inequality. And if these professions are going to meet these students with, not being reimbursed for what they are owed and not being able to afford their student loan payment, then of course you're not going to have the strong enough participation that you need. So at Young Invincibles, part of our mental health agenda is making sure that we're advocating for scholarships. The Health Resource Services Administration offers loan repayment programs to primary physicians, as well as to mental health and behavioral health providers. But a loan repayment program is not the same as a scholarship. And that is another example of how our federal government needs to invest in the future of this workforce. Because what is great about some of the scholarship programs that exist at the federal level is that, you know, they will pay for that education, and then the student commits to working in an area of a physician shortage or in a low income area, and are able to serve those populations through Medicaid in return for the assistance they had getting that education. And so that is a worthwhile investment, but again, we're just not making enough of it.
Fantastic. We have run out of time for this conversation, but I thank all of our speakers and reporters for joining us today for a very robust discussion. Reporters, we will not see you next Friday. We will see you on the 23rd. Take care.